Central component of all CTSAs is community engagement. This afternoon you'll be hearing from the director of the Community Engagement Corps at Rochester. Our program was really built on the shoulders of a strong foundation that was created by Hal Strelnick and a group of partners across our Bronx community, and we're really honored today to have with us Ms. Paloma Izquierdo-Hernandez, who is the President and Chief Executive Officer of the Urban Health Plan, a federally qualified health center located in the South Bronx, which is, as you may know, the poorest congressional district in the country. She began her tenure at Urban Health Plan in 1976 and rose through the ranks and became President and CEO in 1996. Under Ms. Izquierdo-Hernandez's leadership, Urban Health Plan has grown from a one-site facility to a network of 3 health centers, 5 school health programs, 4 sites at facilities for at-risk populations, and 2 administrative facilities that house multiple grant-funded programs. She sits on numerous boards, including those of the Primary Care Development Corporation, the New York City Department of Health and Mental Hygiene Advisory Council, the Community Health Center Association of New York State, Affinity Health Plan, Visiting Nurse Services of New York, and the Joint Commission on the Accreditation of Healthcare Organizations Ambulatory Care Advisory Council. Mrs. Izquierdo-Hernandez was raised in the Bronx. She holds a master's degree in speech pathology from Columbia University Teachers College and a Master of Public Health from Columbia University's Mailman School of Public Health. Mrs. Izquierdo-Hernandez has been recognized nationally for the performance improvement work she spearheads at Urban Health Plan. She is often called upon to speak nationally on best practices she has developed to improve the quality of health care for underserved populations, and I look forward to hearing from her today. Please join me in welcoming Paloma Izquierdo-Hernandez.
Okay, great. Thank you very much. This is a great privilege and honor to be here speaking to so many people from Einstein that some familiar faces I see in the audience, but I really want to thank everyone for this opportunity. It's not always that you get to hear a community's perspective. So I'm not going to talk about any of that fancy stuff, which may not be fancy to you, but to me it is. And I'm going to talk to you about what life is really in the South Bronx and some of the work that we've done, not only that we've done, but that's also reflective of some of the work that's going on in other community health centers throughout the country, and that really pose an opportunity for blending your work together with ours and really making changes. And I would, that little circle that they showed before about how sciences end up in changed practices, I would push it a little bit further and say that it not only should result in changed practices, but that it should actually change policy so that our whole healthcare system can change in a way where what you're doing is reflected and reimbursed and is part of our healthcare system moving forward. So with that, I want to tell you a little bit about Urban Health Plan. We were founded back in 1974 by my dad, who's a physician. He's been practicing in the South Bronx since 1962. It's a real interesting story for those of you who may not be familiar with Dr. Izquierdo, but he started his practice before there was Medicaid and Medicare. So he's been serving the community for a very, very long time, and it's really hard to believe that anyone who has lived in the South Bronx at some point hasn't passed through his hands. We have 34 years of service to the South Bronx community. He started his practice, changed it into a group practice, and then in 1974 we became licensed by New York State as a not-for-profit organization. We now have 4 primary care sites, 3 of which are traditional practice sites in the South Bronx, and we're ready to open one in Corona, Queens. We have 5 school health programs with 3 more coming on, and like I was introduced, we have 2 in homeless shelters, 1 in an adult day treatment program, 1 in a boys and girls club, and our volume, just to give you an idea, is 168,000 visits a year, and we serve about 31,000 different community residents. Our population is mostly Latino. 82% of our population is Latino compared to the population of the community, which is about 73% Latino. This is, I can't bring you there, so I'll bring the community to you. This is what Southern Boulevard looks like. This is what our building looks like, and that little white building below was our old facility. We have been in this new facility now since 2001. When we last were in that little building, we saw 72,000 visits a year. So in 7 years, we have had that tremendous amount of growth. And that's our famous train that completes our community. This is one of our other sites. This is another one. And this is our new Queens site that's brand new and not yet opened. Just to give you a little bit of statistics on our community, in percentages, you could see that the red signifies really lower or higher ratings than when you compare them to the Bronx and New York City. So 43% of the Hunts Point community residents rate their health care as fair or poor. 35% don't have access to primary care. 16% go to the emergency room when they're sick. 9% of the adult population are asthmatics compared to the other numbers that you could see before you, and so forth. And somehow we have good cancer screening rates, which is a nice surprise. And overall, really, the important thing that I want to point out is the amount of people who live in poverty in this community. So I really have recognized that no matter how good health care you provide in an underserved community, if you're not dealing with the social determinants of health and the poverty that exists there, it's almost impossible to really make a dent in the quality of life of the residents of those communities. We also have higher rates of people entering into early prenatal care, teen pregnancies, higher death rates. You name it, we've got it. So our mission is to continuously improve the health status of underserved communities by providing affordable, comprehensive, and high-quality primary and specialty care. And new to our mission is by assuring the performance and advancement of innovative best practices. And I think we really pride ourselves in what we've been able to do within our health center, within our organization, in terms of performance improvement and quality, which I think is just a precursor to delving into the field of research. These are the services we provide, and underneath each one of these are lots and lots of other services. So our primary care is, we have special primary care programs for our HIV population, for our adolescent population, for our elderly population. So this is just a brief overview of what we provide. The one thing that's very unique about federally qualified health centers is the level of support services that we provide. We have lots of enabling services, so social services, health education, intensive case management, which I'll talk a little bit more about, transportation. Those are the enabling services that I think really allow us to make the kind of changes that we can make within our community. So what did we do to respond to the health disparities that exist in our community? We took on a quality transformation process that started back in 2001. And through that process, the organization has totally changed. Everyone you speak to in our organization, performance improvement is the top thing that everyone talks about. Everything we do is focused around how can we do things better. And I want to share a little bit of what our outcomes have been in doing this quality work, but I also want to mention this Project Hope because it's a really cool project that we just started in the Hunts Point community. Hunts Point, the peninsula, for those of you who are familiar with the Hunts Point Peninsula, have only 10,000 residents, and it is really, it's out there. It's separated by the Bruckner Expressway, and it just sits out there. And it's surrounded on its periphery by industrial park and food distribution centers. So there really is a great opportunity to really make a lot of change there. So we were funded recently by the Office of Minority Health to start this Project Hope, and HOPE stands for Health Outcomes Through Peer Education. And what we want to do is take on a door-to-door, block-to-block, building-by-building approach where we could actually create and develop health ambassadors who will help us reduce the health disparities within the community. So one day I'll come back and tell you about how successful we've been, because I really think that having assisted our president-elect in campaigning, I know that grassroots organizing really does work. So we've taken on asthma, depression, HIV, diabetes, cancer screening, childhood obesity, geriatrics, our pediatric prevention, and teen pregnancy as some of the issues that we've tried to address. Our asthma outcomes, For those of you who may or may not be familiar with our asthma outcomes, we've been recognized by the Environmental Protection Agency with the National Exemplary Award for our asthma management program. We currently serve about 5,900 asthmatic patients, and we've been able to reduce hospitalizations for children by 60%. Within our entire community. And for a little while, we had the health department believe that maybe it was that the air was moving in a different direction. And by the second year of the same kind of results, they actually said that maybe we had something to do with this. So our symptom-free days, which is really our outcome measure, and it's self-reported, is that those 5,900 patients over the course of a year, on average, report 10.8 symptom-free days out of 14, with the goal being 10. Our persistent asthmatics on anti-inflammatory medications is 97.2, so it's really astounding that we've been able to accomplish what we have been able to accomplish. And we just are recently involved with the health department and with Affinity Health Plan, and Affinity has been able to show that we cost them 22 to 40% less on asthma care when compared to the rest of their network. So, and that was really important because we always wanted to show that there's a real business case that could be made for quality work. And so we're really excited about that. Our depression outcomes, again, we have a 60% reduction in depression screening scores for our over 700 clinically significantly depressed patients. 82% of our HIV patients are practicing safe behaviors. Our hemoglobin A1C levels, we're still working on them, but within our geriatric population, which is a very specific program that we're developing, you could see that over age 65, we've achieved a 7.2 hemoglobin A1C average level. Cancer screening, again, we've had increases in mammography rates. 50% of our elderly population have received the pneumococcal vaccination. Immunizations, 90% of our kids at age 2 are up to date on immunizations, and 96.3% of our teens report not having had a pregnancy. So we really have responded to the health disparities issues that are out there that are facing our community. Childhood obesity is a real interesting one because, as you all know, there is no evidence-based guidelines for the treatment of childhood obesity, yet we have intervened, and 11% of our kids by age 3 are underweight, 76% of them are at healthy weights, 4% are overweight, and 9% are obese, compared to the other rates that you see right before you. Well, so that we've been doing an outstanding job. And the trick, especially in childhood obesity, because it is so new and so relevant at this point, is really trying to evaluate what is it that we've done and what is it that could be done in other communities so that they could see similar results. How did we accomplish all these things? We institutionalized the Quality Institute. We adopted a chronic care model. I'm not sure how many of you are familiar with it, but it is a way of looking at treatment and looking at quality in a special way. We've tested many interventions, we've changed our practices, and we've implemented an electronic health record. And lots of people will say, well, that was it, the electronic health record. No, the electronic health record actually hindered our progress because the data that we've been collecting, you can't easily collect it on an electronic health record. Those are more registry functions that allow you to track the data that we were tracking. But the electronic health record, once you get it into place, really, really is beneficial in assisting physicians with decision support tools and really being able to remind them of what needs to be done for the patients. So initially it's not helpful, but over the long haul it is very, very helpful. So what this has resulted in, and some of the changes that we've seen, is we have now intensive case management services at the point of care. We have a very successful telephone case management program. We have health education and nutrition at the point of care. We have intensive physician engagement and education, and through a focus group we actually identified that that was the one change that really affected childhood obesity rates in our health center. Improved decision support capabilities really through our EHR. We integrate self-management goals into all patient care that we provide. We are able to track outcomes, and we're starting now to rigorously evaluate how effective these things are. So what's next for us? if we looked at the different levels of technology within primary care settings, mostly mine, I would tell you, I would say that what you need to start with is good internet connectivity, so all your health centers are all connected properly. Built upon that is a robust IT structure that can support all the technology work that needs to be put into place. Then have an integrated practice management system with an electronic health record. Built upon that, good clinical decision support and registry functionality so that you could produce the data. Continuous quality improvement, and at the end is really clinical trials and research. So I believe that we have all the data that's required to be able to take us to the next level, where we could really demonstrate that what we do can be evaluated, can be standardized, can be really looked at very differently than just how we're looking at it from a quality perspective. So our research involvement has been with multiple clinical directors network projects, and Dr. Tobin is here, who's a great friend, and we work very closely together in doing multiple research projects with the CDN. Our chief medical officer is on their IRB board. We are involved with the Hispanic Health Study out of Einstein, and we have written some proposals with the New York Academy of Medicine that are yet to be funded. So how do we get from internal quality to internal research? I think we have to look at and really realize that this is not what we do. What we do is we provide care. We don't do research. And that's why it's important that the partnerships are really developed with people like you who could take the innovative practices that we're now implementing and really evaluate them in such a way that they could be then transported and exported to other communities and to other settings. So we basically lack funding, expertise, resources, time, partners. We lack it all in order to do research, but we're really at the point where that's where we really should be. And not to do it is almost an in-service because of the quality of the work that we have been proven to do within our own walls. So translational research, what it means to me, is the process which leads from evidence-based medicine to sustainable solutions for health problems, developing broad-based teams of scientists and scholars who are able to focus their efforts to link basic scientific discoveries and translating the results of clinical trial into changes in clinical practice. And I think it's a continuum of trials to testing and practice to sustainable solution, and I would add to sustainable policy changes. And to me, in order to do translational research with organizations like us, it has to be done through a community-based participatory research approach. And what are the potential benefits of doing this? I think inclusion of the community in projects as partners, not as subjects, is really important. Recruitment of subjects by the community. Development of the design, using our expertise in helping design those methods so that they are appropriate, they're culturally sensitive, that they fit within the community models. Connecting community members with how research is conducted and what comes out of it. I would say that our communities are pretty ignorant in terms of what does it really mean to do research and what can they positively gain from it. And providing immediate benefits from the results of the research. I think that's crucially important, especially in underserved communities. We're usually the last ones to get the best of anything. And I think being in the forefront and working together with folks like you can really make that change happen. So what are some of the challenges? And you can see there are lots of challenges. And while I was sitting here, I was thinking one of the biggest challenges is the way you think and the way I think. And I think we have to think together and really learn to appreciate where you're coming from and where we're coming from. And as I was sitting there, I was listening to the level of probing that you have to do as researchers, and that's recognizable. You have to probe. But our perspective as advocates is to protect. So how you marry those two is really, really important and something that you have to understand exists with us. There's lots of ethical concerns about things that have happened in the past, and those are ever in people's minds. So no matter how much they're gone and they're done with, I'm not sure that they're gone and done with from our own history and our own thinking. Lack of resource sharing. So when you come to me, I'd like some of your resources that you've been funded to get. It's not a one-way street. If you have some resources, share them with us. Make us co-principal investigators. Make us really a part of the process. Real community involvement versus a paternalistic approach. And I really hate to say these things to all of you, but that's how it feels sometimes, and it doesn't feel very good. Inadequate community incentives. You know, when you have people coming in and you're sitting them there for a full day of testing and you pay them $75 for the day, that's really not appropriate. And those are the things that make this difficult to do together. So the incentives and the compensation for community members really have to be aligned and appropriate for what we're requesting. Community benefits left behind. If it's an improved treatment, great. But sometimes you come into the community, you do your work, and you leave, and we're left with, we've given time, we've given energy, we've given our patients, and there's nothing left to show for it. Obsession with genetics. And you know, while I was writing this, I was thinking, why am I writing this? But it's clear, and after I saw the two presentations, it's very clear. But from our perspective, there is a lot of information we want to protect, and we want to protect our communities from. And I understand that it's hard for you to do your work without that. And there has to be a mutual understanding of what it means, and being able to put it out in the open and clearly stated in informed consent forms so that there is no misunderstanding and the trust could just be put out there so that this works. Lack of researchers who look like the community. Unfortunately, we don't have a lot of researchers who are people of color, and I think that's something that we really all need to work on and change. Lack of long-term partnerships. So if we develop a partnership with you, let's make sure that it's long-lasting, so that we become one over time. And perceptions of feeling used. So what are some recommended strategies to overcome this? And I think I've spoken to many of them, but view each other as equal partners. Include us in your IRB. Really put real community people on the IRB, and I know for the CDN, they have real community people on the IRB. But oftentimes that's not the case. So we have a person who may no longer be working with the institution, but they live in the community, so they become the IRB community member. And that kind of thinking has to alter as well. Learn to respect each other for each other's work, trust the relationship and the work. Really respect the community leaders and understand what we bring to the table. Be sensitive to our concerns, stigma, labeling, or overgeneralization, which all comes out of the obsession with genetics. Clear, informed consent. Express and demonstrate a desire to do good. I know that ultimately that's what you really want to do, but let's make sure it's put on the table so people understand that. Leave behind the community benefit, respect the community's time and incentivize accordingly, and assist in developing a diverse workforce. And if I could leave you with a take-home message, it's really that change is here, and we've seen it. We see it in our society. It's in our hands to do. I believe that, like President-elect Obama says, yes, we can. And I think if we all put our heads together and we're really concerned about the health of the patients that we serve, of the people that you're interested in researching, that we can make a difference and we can do it together. So thank you very much.